Good evening, everyone. Welcome to NZUSI postgrad teaching class third session. And as you know, we started this kind of program last year, and this year under the leadership of Dr. Sudhir Rawal, we are continuing the same protocol. And the last sessions, they were appreciated by our residents, and we were requested to continue for one or two more sessions. So today is the third session, and we'll do one more session in the last week of this month. So I will first request our Honorable President, NZUSI, Dr. Sudhir Rawal, sir. Under his able guidance, we are trying to achieve the newer heights to give his welcome address.
Thank you, Anup, and it's my pleasure to welcome you all for this third postgraduate teaching session where teachers are Ravindra Sabnis. He's teacher of teachers. I have seen him presenting many times panel discussion and all, and I always enjoyed his session. And then Dr. Arun Chawla, who is professor in Manipal. He is a great teacher, and Salim Wani, another great teacher. And we have two moderator, Umesh Sharma. I think most of the young guys know him. He's a very good surgeon. And then we have Dr. Gautam Ram Chaudhary. He's from AIMS Jodhpur. So we have excellent faculty, and I hope the students will learn a lot, and they will be confident after the session once it is over, and in the near future we will have another class also. So with that, I welcome you all. I will not talk today pandemic at all. Thank you.
Thank you very much, Dr. Rawal, sir. And indeed, India is recovering from the pandemic now. That's a good news. So now I will request USI President, Dr. Mallikarjun, sir, under whose able leadership USI is achieving newer heights. And we are really grateful to him that he has taken out his precious time to come and address us for this session. So I will request him to give his welcome address.
Thank you, Anup. First of all, I should congratulate North Zone, led by Dr. Sudhir Rawal, and with the secretaryship of you, doing an excellent job regarding the postgraduate teaching programs as concerned. I just have a vivid memory of the last few weeks ago that you had one program, and again, I'm realizing that there's one more program happening. I understand that is the need of an hour because of some sort of a problem regarding the training of the residents. But I would always say the present resident generation, though COVID is one roadblock, but otherwise are blessed people with so much of activity and so much of various ways of learning with so many people on a Zoom platform. We never could have this sort of a thing in our residency times at that time. But anyway, with this sort of a program, it will be great of some great use for these people. And congratulate you for continuing these programs, and I hope this will continue forever too. Thank you very much.
Thank you very much, Dr. Mallikarjun, sir, for your kind words. And we are grateful to USI for their continuous support and motivation to the North Zone chapter of USI so that we can continue with these kind of activities. And now I am going to request USI Honorary Secretary, Dr. Keshav Murthy, sir. Again, I want to thank him for his continuous support and motivation to our all activities. And he has taken out his precious time for today's session. So I'm really grateful to him. And I will request him to give his opening remarks. Dr. Keshav Murthy, sir.
Thank you, Dr. Anup, and greetings from USI. It's a wonderful program which last two sessions I have attended, and it's a good method of teaching now for the students. And we have a good lineup of faculty today: Dr. Sabnis, Dr. Salim Wani, and Dr. Arun Chawla. I'm sure the students will be benefited by this teaching program. I wish you all the best. Over to you, Dr. Anup.
Thank you very much, Dr. Keshav Murthy, sir. So, like we are continuing the same protocol, today also two cases will be discussed, and we give 1 full hour to one case so that the students can discuss the whole case, and they also get the takeaway message from the same case. So the first case will be moderated by Dr. Umesh Sharma. He's the associate professor in RML Hospital. And for today's session, we have three very esteemed teachers from India. They do not need any introduction. Just for the session, I want to introduce them formally. Dr. Sabnis, he's our president-elect of USI, and truly he's one of the teachers of the teacher for so many years. And we are grateful to him that he has taken out his precious time for our students today. And he always has that great passion for teaching the residents. Then we have Dr. Arun Chawla. He is our co-chairman of Indian School of Urology. And for last 2 years, we are seeing him doing so many activities and helping our residents. And he's again a very great teacher from Manipal. And we also grateful to him for accepting our invitation. And then we have Dr. Salim Wani. Again, he is a professor and head of department from Sher-e-Kashmir, very prestigious institute from Kashmir. He's a very renowned academician and very, very popular amongst residents. So we are grateful to him that he has accepted our invitation. So I will request now Dr. Umesh to start sharing his presentation. He will start moderating the case. And for the first case, we have 3 students. Each student will be given 20 minutes each to appear for the Viva. And after 20 minutes, we switch to the next student. So please, Dr. Umesh, you can start sharing your screen. And the first student will be Dr. Prashant. And please put your audio visual on. I will request students to please use the earphone so that we can hear you properly and speak loudly and slowly so that the teachers can listen you properly. So over to Dr. Umesh.
Thank you, sir. Good evening, all of you. Good evening, all the teachers and respected teachers, senior members, USI, Indian School of Urology, and Northern USI, giving me this opportunity so that I can present this case. My slides are visible, sir?
Not yet.
No, you need to share your slides.
Yeah. Meanwhile, Dr. Prashant is ready.
Sir, good evening, sir.
Okay.
Hope my slides are visible, sir, now?
No.
Not yet.
Cannot see. So Dr. Umesh, please open your PPT, make it half screen and then select that PPT again.
I have opened the PPT and
Make it half screen. Make it half screen and then you select it.
okay. Make it
Then
Meanwhile,
share. Then click the share.
Then click the share.
If you have already opened, then stop share and then start share again.
Sir, actually, I am seeing desktop on Microsoft something.
So if Dr. Umesh, you are having technical issues, we can go ahead with firstly Dr. Gautam's case and then we come back to you. Meanwhile, we'll try to rectify your audiovisual issue. So Dr. Gautam, you can start sharing your case now and Dr. Umesh can present the second case.
Yes, sir. I am sharing.
Yeah.
So this is my case. Can you see, sir?
Yeah, we can see that.
Yeah, we can.
Okay.
Yeah.
So let me start. Who is the first candidate, sir?
Who are the students?
Dr. Prashant. Dr.
Myself,
Prashant.
Dr. Prashant, sir.
Yeah.
Okay. So Dr. Prashant, how are you?
So I'm fine, sir.
Fine. Okay. So let me start with the case. First of all, thank you USI and Anup sir for the opportunity, and it's indeed pleasure to see all stalwarts on the web, online, and thank you everyone. So let me start the case. So she is 32-year-old female homemaker presented with the complaint of right flank pain on and off for the last 6 months. What else you want, Prashant?
Sir, I'd like to elaborate about the flank pain which she is having for past 6 months, sir. In that case, I would like to ask about the nature of the pain, the character of the pain, the radiation of pain, the association of pain with the nausea and vomiting, then some aggravating factors if it is having, and how it got relieved, whether of its own or whether it got relieved with oral analgesics or IV antibiotics, and whether she required any admission for that.
Okay. Anything else you want to know about the pain? What do you mean by the character of pain?
So, character of pain, I like to first of all find out whether it is a colicky type of a pain or a continuous type of a pain.
Okay.
And then the nature of the pain, sir, and the intensity of the pain also, sir.
All right. Okay. So these are the things which you want to know about the this. How you are going to differentiate your differential diagnosis by the character of pain? Can you just elaborate on that? Suppose
Sir,
a patient says that it is off and on colicky pain for last 6 months, as against to a person who says that it is continuous dull aching pain for last 6 months. So how what comes in your mind?
Sir, if the patient complains of on and off pain with intermittent exacerbations, first differential diagnosis I can consider is a renal stone disease, sir, or a ureteric stone disease. However, if the pain is a continuous type of a pain, in that case, it is more towards a pathology which is continuously compressing onto the PCS, sir. Maybe a malignancy itself,
Okay, that's
or
all
maybe
right.
some
So
other
you can
things.
elaborate that a little later. So these are the things about the pain you want to know. So can you show what about the pain characteristics?
So pain was situated in the right flame. It was insidious onset, mild to moderate colicky. Sometimes require oral analgesics only, non-radiating. Intensity has increased over the past 1 month. Earlier for 5 months it was less intense. No specific aggravating or relieving factors.
All right. So you got the things about the pain. Now, next thing is that any other negative history you want to ask, because now she has presented only with the pain. Now it is your job to elaborate any important positive or negative history. So just go to that.
Sir,
So what other history you will ask for?
in this, I'll ask her first of all about the any swelling over the flank or any swelling over the abdomen, sir. And if there was any swelling, then whether the swelling was increasing in size or it was static, sir. Then
Okay.
I would like to ask about whether it was preceded by some trauma or not, sir.
Okay.
Then
What else?
Then whether it has any association with the act of urination, sir. Whether it got relieved after the act of urination or it is increased during the urination.
What sort of things in your mind when you ask for this? Which pain aggravates after urination and which pain gets relieved after urination?
Sir, if the pain is because of some reflux, like vesico-ureteric reflux, in that case, the patient may complain of increase in pain during the urination, sir. However, if it is because of a gross hydronephrosis, it may have a relief after the act of picturation.
Okay, what else?
Then I would like to ask about whether the pain was associated with any fever, with chills, and also associated with any lower urinary tract symptoms in the form of storage symptoms or voiding symptoms. Then I would like to ask about whether it was associated with any hematuria or lithuria.
Okay. Hematuria,
And
lithuria,
pyuria, sir.
Pyuria. Okay. What else?
Then
any other important negative history, positive history? See, these are all long cases. We are going to discuss for 1 month. So we are going to discuss in detail about every aspect of the, so that once for all, everything is discussed about this case.
Sir.
So what else you would like to ask for?
Then I like to ask about if whether in the history of present illness, whether there was associated weight loss, loss of appetite, or any evening rise of temperature.
Okay. What else?
And then
what
if then I can ask about the symptoms of pulmonary symptoms or jaundice.
What do you mean by that?
So in that case, if although the age of the patient is less, but still if the patient may have some malignant pathology, in that case, I have to rule out certain metastatic symptoms also in that case.
Okay, what next? What else? What else?
Then, sir,
whenever the case is like this is a very common. I mean, most of you get a case of a flank pain. So in that case, you have to go in a very systematic manner about the asking for positive, negative history. How you go about it is that first all the symptoms of recurrent urinary tract infection. because everything will get covered in that, whatever differential diagnosis is in your mind, whether it is stone, whether it is obstruction, whether it is what. So there are clear-cut symptoms which you have to ask for when you think of a recurrent urinary tract infection. Then, as you said, the malignancy, as you said, chronic infection. Then the other thing which you have to ask for, any trauma, which you have already asked for. So these are the, if you go in a systematic manner. The other important thing is that symptoms of renal insufficiency. You don't know whether it's a solitary kidney, there is a flank pain, and whether, so you have to elaborate that history in the form of puffiness of face, edema feet, whether there is any breathlessness on walking, whether there is a fatigue, whether there is a dyspnea on exertion or not. So if you go in a systematic manner, the symptom complex, then you will cover almost everything. All right.
Okay.
So Dr. Gautam, tell us anything in the positive in the history.
Yes, sir. So this patient was having the pain was associated with few episodes of fever, though the temperature was not measured, and also she had the dysuria and the frequency, no GI symptoms.
Okay.
And further negative history, no hematuria.
Go back 1 second.
Mm-hmm.
So Dr. Prashant, are you happy with this history?
Sir.
Are you happy with this history?
Sir, then I have to ask further about the positive and negative history, what I have asked.
Sure.
No. See what he has written, few episodes of fever, dysuria frequency, no nausea, vomiting. So are you happy with that, or you want to have some elaboration?
But I want to elaborate about the fever, sir, and the symptoms of frequency, whether it was a daytime or a nighttime frequency.
Good.
And then the fever also.
So whenever there is a history of fever, you need to have a more elaboration of the fever,
elaboration of fever,
low grade fever, whether the recurrent high grade fever, whether it is evening rise of fever, or whether patient gets high grade episodes of fever off and on.
Sure.
And about the what do you understand about dysuria and frequency? What elaboration more you want? See, this is a 32-year-old female.
Sir, the dysuria, it's okay, but the frequency, how many times is she passing urine, sir?
There is a
and how much
dysuria, you need to ask the frequency, daytime, nighttime,
and
the urgency
urine output also.
Yeah, so that will give you idea. Okay, anything else? Dr. Gautam, tell us whatever he has asked for, if you have any other question.
Yes, sir. So she also never had hematuria, no obstructive lower urinary tract symptoms, no other system involvement, GI, CVS, and no history of loss of weight.
Okay, now tell me, Dr. Prashant, anything else you want to ask, keeping in mind that this is a 32-year-old female?
In the history of present
with the right side flank pain.
Sir. So in the history of present illness, I think the previously what I have discussed, that was suffice in the history of present illness. I'll ask.
Right. That is all right. That understood. Anything more than that? What happens with 32-year-old female? Now, do you want to know about her obstetric history? Married, not married, previous LSCS,
sir,
previous.
So that will come in the obstetric and the menstrual histories. In the history of present illness.
Go ahead, and any other history you want to ask for.
Okay, sir. Should I reveal the future slides? Okay. So in personal history, no similar illness in past, no comorbidities, and no previous surgeries or hospitalization. Of history, she is a married female, LMP 10 days ago, regular cycle, and one live issue 4 years ago, full-term normal vaginal delivery.
Okay. All right.
Okay. Should I proceed further?
No. So are you finished with the history, Dr. Prashant? Everything is over, or you want to still know something more? Or now you want to go for examination?
Now I'd like to go for the addiction history, sir, and the occupation, sir, and her socioeconomic status, what she is doing, sir, where does she live, sir.
All right. Okay. Anything else? And that suffices everything. But the important thing is that have you asked for bowel symptoms or bowel habits, whether she is constipated or not constipated? Any patient with flank pain and some dysuria frequency, make it a habit to ask for the bowel disturbances. Okay. Because somewhere it may get correlated with this, because now the presenting complaint is only flank pain and you have to think over it. So whether she has any constipation, what is the bowel habits, whether she has to take any medications for constipation or not. So that is all important things. Okay.
Sure.
All right. Dr. Vani, you want to ask anything else to him?
Dr. Prashant, you said that. Yes, Dr. Prashant.
Sir.
Would you like to? You have not asked the history of any instrumentation in this patient. She's a female. Has she ever had any instrumentation in the form of catheterization? If we want to rule out the urinary tract infection, the recurrent urinary tract infections.
So in the past history, it's been written that she had not undergone any surgery, sir. But
no,
previously
surgery
I was
is different.
discussing.
Surgery is different. What about the catheterizations, which usually they get during deliveries?
Sir.
She had normal delivery. Because that is the time when they most often these females get an introduction of urinary tract gets infected.
So any previous instrumentation is important. Okay.
Sir.
So you, go ahead and show the examination findings, Dr. Gautam.
Yes, sir. Still the personal history was left, and it sees a vegetarian, regular bowel habits, and family history not significant, no addiction. So in examination, thin-built female, BMI 19, general examination within normal limit. Right now, abfebrile, and the vitals are within normal limits.
Go ahead with systemic other examination.
So in abdomen is also scaphoid, umbilical, central, inverted, no lump, and normal bowel sounds. In chest, bilateral equal entries. That's clear. Should move further.
All right, Dr. Prashant, anything else you want to know, or with the history and examination you are over, you are happy with everything, whatever is provided? Or you want to know anything else, you can ask for it, and then we can go ahead with the case. Are you happy?
No, sir, it's it suffices, sir.
Okay, so now history is over, examination is over. So let us come to the differential diagnosis.
Well, Dr. Sabri, since she's a female, I would like to ask is your examination, Dr. Prashant, complete without a DRE or a pervaginal examination in a patient where you are dealing with and chance of infection or anything?
Correct.
She may be having the.
That's important point.
Because that is not mentioned. Your examination, you cannot say that my examination is complete without DRE and a pervaginal examination in a female and a speculum examination if you are dealing with a recurrent urinary tract infection.
Sir.
Yeah, I think that is important. Huh? Dr. Chawla, you want to add anything to whatever he has?
No, sir. Little details about the constitutional symptom which the patient had. And number two, any history of tubectomy or any gynecological procedure if the patient had. And number three, little detail about the lower urinary tract symptoms, frequency, urgency, their bothersome scale, and that's the three things I wanted to know.
Okay, so let's go ahead with differential diagnosis. Put differential diagnosis in the order of priority.
Sir, my first differential diagnosis will be genitourinary tuberculosis, sir. The points in favor of
tuberculosis. Why?
So the patient is complaining of the right flank pain, and also she is having the storage symptoms in the form of frequency and dysuria, sir. Her age is also 32 years of age, and she is from our country, and also she is thinly built, sir, and moderately nourished.
Why not
you
simple?
want to
Why not
keep
simple acute
GUTB
bacterial
as the first
infection?
diagnosis?
Why not
GUTB
simple
as
acute
the
bacterial
first
infection?
diagnosis. Why not stone?
So it can be, sir. The stone in the lower ureter can be a possibility, sir.
Why lower ureter? Why not in the kidney?
The symptoms of frequency and the dysuria are also associated with the right flank pain, sir. So in that case, it may be more chances of a distal ureter calculus, and then it can be a renal stone, sir.
The
Prashant,
symptoms
if
are
you-
from 6 months for this patient.
Prashant, if you can come from more common to less common possibilities, that will be good. If you can number it
Remember-
1, 2, 3,
remember
4,
in
or
differential
differential
diagnosis,
diagnosis, then we'll go ahead.
You have to
Why
give
not?
the
Why not,
common diagnosis
Dr. Prashant?
first and then come later on to the other
Doc-
common. Don't say
Why
diagnosis of BUTB first.
Yes, that's what Dr. Sabnis, I just wanted to ask. Why not simple cystitis bacterial, acute bacterial infection rather than recurrent bacterial infection of the lower tract rather than a GUT?
Right.
Sir, I think it's a time to change the student now. So I will request Dr. Pawan to take over. Please keep your audio visual on.
Okay.
Hello, sir. Good evening, sir.
Yeah, okay.
Am I audible, sir?
Yeah. So,
Yes.
Dr. Paul,
Yeah, Pawan.
now tell us what is your differential diagnosis. Let us go very fast. You don't want to get stuck at the diagnosis because there are a lot of things we need to discuss. We have only.
Sir,
40 minutes.
I would like to keep my first differential diagnosis as renal calculi with secondary separate with cystitis, a separate entity, renal calculi plus cystitis.
What else?
The second differential diagnosis could be right-sided PUGO with cystitis, as she's a female. It can be, sir, third differential diagnosis I would like to keep as right-sided genitourinary tuberculosis.
Okay.
And fourth differential diagnosis I would like to keep as right-sided ureterosole.
Okay.
And my last differential diagnosis would be, sir, right-side renal mass.
Right side renal mass. See, when you are asked for differential diagnosis, see this patient, what is positive in this case? It is only right flank pain. And there
Yes,
is some frequency dysuria, but specifically on asking, there is no obstructive LUTS, and on examination, there is nothing. Almost
Yes.
everything is normal. So
Yes, sir.
you have to make a differential diagnosis in a 32 years old female only on the right flank pain. So all the causes which are there for the right flank pain will come from the order of priority. So what you said is correct, but over and above that, anything in which there is an obstruction, whether it is a PUJ obstruction, whether it is a uretrovesical obstruction, whether it is a stricture, whether it is stone, whether it is this, everything will come. As you said, it is ureterocele, everything will come. What else will come? Because it's a right flank pain, which is just vague. You know, it is for 6 months. Where you can get the pain either because of the obstruction in the path, secondly, because of the infection in the parenchyma, thirdly, because of the stretching of the renal capsule. Now that stretching can happen because of any hydronephrosis, any cyst, or any other disease where it will cause a problem. So if you go in that systematic manner, then you will not miss any differential diagnosis. Why you want to keep malignancy as a last? What malignancy you are keeping as a diagnosis?
Sir, right-sided renal mass like RCC can be. It's my last differential diagnosis, sir.
What is there in the history which tells you that it could be malignancy?
In the history and examination to support. See, when you say any differential diagnosis, whether it is the last or not, it is there in your list. So for every differential diagnosis, there has to be points which are in favor, and there has to be points which are not in favor. So what are the points in favor of RCC?
Is there any?
Sir, as such, there are no positive findings in history, sir, regarding renal mass.
Then why you want to keep?
So don't keep it.
Yes, sir.
See, this is where people come in trap, that you keep a diagnosis, and then if you are asked, what are the points in favor? You say, no, there is nothing in favor. Then why you want to keep it? You don't have to just keep on telling, just because examiner asks what is, doesn't mean you keep telling anything. Tomorrow you can say anything. So that doesn't mean, no, there is no suggestion of that. So you stop at whatever you feel is appropriate.
Yes, sir.
All right.
Pawan, how can renal masses present with pain and fever?
Sir. Sir, fever can be an extra. It can be a manifestation of renal mass, sir, and pain, sir.
How it can be? How many cases of renal malignancy present with pain and with episodes of fever?
And the next question is that what are the reasons of patient getting fever in
fever?
The
in a tumor.
What are the reasons and what sort of fever they get in RCC?
Sir, when there is a large tumor, there is intratumoral lysis or necrosis in the tumor, it can present with a fever, sir.
And what sort of fever it is? Is it high grade or it's low grade or it is occasional fever off and on? What sort of fever do they get?
Sir, it will be a low grade fever.
Okay. So if you think that it's a large tumor causing necrosis and that's a lysis and that is causing fever, then what other symptoms should be there associated with that? If you think from that angle.
On examination, there would be a palpable mass in the abdomen, sir.
Is it there?
No, sir, there is no mass. No mass.
What should be there? See, all these questions actually are unnecessary because you have put your foot into it. Now, these questions which I'm asking, this is what happens in exam. I mean, this is good that the mock exam is happening, so you understand. But this is exactly what happens in exam, that you utter something and then examiner asks something on that. Then the whole direction changes and all these questions which we are asking does not carry any mark because it is irrelevant to the case. So time is wasted. You have very limited time. Now, if you waste your time, then the fruitful discussion, there is no time. And then the impression is, no, he's an average candidate. It's okay. Either P plus or P minus, something is borderline. So that is what happens. All right. So go ahead now. How will you investigate?
Sir, I would like to evaluate the patient.
No, keep it back.
Yeah, Dr. Chawla, you want to?
No, I just wanted not to show him the investigation. Let him ask.
Yes, not it. Okay, sir.
Sir, I would like to go for urine analysis of this patient, sir. Urine routine microscopy and the urine culture and sensitivity, followed by
no, show whatever you ask for. Urine, show urine. Whatever you ask for, you can tell. If there is nothing, then you can just tell also.
Yes, sir. This is the urine examination.
Okay, so urine does not. Urine. What does urine show? 10 per high power, RBC3, no bacteria, urine culture sterile.
And I'd like to go for, sir, serum.
Pawan, just stop.
Hold on.
Pawan,
hold on.
Tell me just what is the significance of this?
Dr. Pawan, hold on. What
is the significance of this?
Would you like? Is this urine examination complete?
Sir, proteinuria is not
does it give you all picture about the disease you are looking for?
No, sir.
What would you like to have?
No, don't show him. Just ask him.
Yes. I'm just making it very small so he can't see.
Okay.
Can you see my
just this
left
urine
leg?
examination? Just this urine examination. Is it giving you the information which you are looking for? If not, what else would you look for in this urine?
Sir, I would like to look for any casts or crystals or and a pH of the urine.
The pH of the urine. Why?
Sir, to rule out any stone diseases like with alkaline pH, we might get a stack on calculus.
Stone or something else when we are dealing with this case. pH is more important in stone or some other condition.
Like, sir. To rule out any tuberculosis.
So what happens to pH?
Sir, it will be acidic, slightly acidic pH, sir.
Okay.
What is the normal?
Sir, 5.5 to 6.5.
So what happens in tuberculosis? Okay, let us assume what is not given is normal. What is the significance of this report which you are seeing?
Sir, as the patient is having
No,
lower
just
urinary
come to.
tract,
No, don't go there.
sterile
Question asked
pyuria.
is, okay, what does it mean? In which condition you find sterile pyuria?
Sir, in patients with renal stones or in patients with GUTB and patients who have taken antibiotics, we can get sterile pyuria, sir.
Any other conditions?
In patient with CIs, bladder CIs.
No, what you have to do is you have to think what possibilities you thought of as a differential diagnosis. And when you were asked which investigation, you told urine examination. When you ask for urine examination, you should be knowing that what you are looking at, is it helping in your diagnosis or not?
Yes, sir.
All right. So what next you want to know?
We want you to know about the causes of sterile pyuria, but for the sake of time, we move ahead. Now, next what?
What next investigation?
Sir, I'd like to go for urine AFB to rule out GUTB.
No, the report is awaited. We have sent that. Please tell us how you will send the urine for AFB.
Sir, it will be the first morning void sample, not the second morning void sample, sir.
No, when you told first morning, see, Pawan, in examination, you have to be very clear. When you told first morning sample, is not second morning. So, you are telling first morning, don't waste your words.
You said first void sample, no?
First void sample will be discarded, sir. The next sample I'll give for the sampling.
Discarded.
Why is that?
Discarded.
Why is that? Why you want to
because overnight there will be denaturation of the cells due to overnight stasis of the urine because of the stasis of the urine.
No, you are talking about freshly voided sample for cytology or for AFB?
What is in your mind?
AFB. Sorry, sir. For AFB. For AFB,
for
sir.
AFB, what will you do?
First voided sample.
In your ward, how you send the sample in your ward when you are suspecting any patient with urinary tract tuberculosis?
First void sample for consecutively for 3 days, sir.
Consecutively for
first void or second void?
3 to 5 days.
First void or second void? Let it be clear. First void or second void?
First void, sir. I just confused with CI bladder cytology, sir.
No problem.
To be collected in which container?
That's important. It's important.
Why you want to do 3 to 5 days?
Sir, as the sensitivity of this urine acid fast bacillus is very less.
So why not do for 10 days? Still more sensitivity, no? Why not 10 days? Why 3 days? Why 5 days? Why not 10 days? No, there is a reason.
You have, Pawan, you have told urine for AFB. You have not told urine for AFB, your culture for AFB. Your answers are going off tangent. In exams, we have very less time. Be specific in your answer. 3 to 5 first morning consecutive samples to be collected in which container? You have to be very quick.
Sir. And
okay, go ahead. Okay, fine. This sample is sent. Report is awaited. Till that time, what you will do?
What next investigation you want to do?
Sir, I can send the urine culture also, sir, for acid fast.
It's written sterile pyuria, man.
It's already written.
For sir, tuberculosis culture, specific culture
we
like.
Have sent your sample. We have sent for AFB, smear, and culture to solid media. Okay.
Sir, I would like to get ultrasound of the abdomen.
You don't want any CBC or anything? You don't want any other investigation? Why you want?
I would like to get, sir, CBC, blood urea, creatinine, and ESR, LFT.
So that don't forget all those routine investigations. Don't jump directly to ultrasound or something.
Yes, sir.
So go in a systematic manner. So this is hemoglobin, total count. Creatinine is 1.02. ESR is 38. Yes. Okay. What other things you want to know?
Sir, I would like to know LFT of the patient.
Why LFT now?
Sir, if you are suspecting GUTB, then later on, when you
later on, have you made the diagnosis? Your diagnosis may
No,
be
sir.
stone.
Come to diagnosis first.
Why you want to investigate later on? Because you have to see, remember, the investigations pattern should be first to establish diagnosis.
Yes,
You
sir.
don't investigate for metastasis before even making the diagnosis of CA prostate, because later on it may turn out to be CA prostate. It is not
Yes, sir.
like that. This may be a clear-cut case of stone. Why you want to do all this LFT and other things? There is no need.
Yes,
If
sir.
you establish diagnosis and when you want to start, then you can do it again. Otherwise,
Yes,
you
sir.
are wasting investigation. No?
Then I would like to get
you want to do
ultrasound.
ultrasound. All right.
Yes, sir.
Ultrasound batao, chalo, ultrasound batao. Okay, this is right side kidney.
Sir, there in ultrasound, sir, there is a moderate dilatation of the pelvic calyceal system.
Okay.
And there are no stones visible. There are no stones.
No, in a given picture, when you are asked to describe ultrasound, it should come in a very quick manner because it doesn't require much time.
Pawan, you kept so many possibilities. You have got the ultrasound of a affected side kidney, and you have given only 2 findings. That's not correct.
Sir, the ultrasound, the right kidney shows there is moderate dilatation of the pelvic calyceal system, and upper ureter appears to be normal.
Don't say
and,
normal. It is not seen.
Not seen, and there is no evidence of stones or any renal any mass in the given pictures.
See, when you are describing ultrasound, first and foremost, you start with the shape of the kidney, whether it is smooth surface, whether it is irregular surface. How is the cortex? Whether it is a good thick cortex, whether it is a echogenic cortex, whether it is a variable thickness cortex. Then you come to pelvic calyceal system. Then you come to stone. Then you come to any other abnormality which you find out. So if you go in a systematic manner, you will not miss anything.
Sir, surface appears to be smooth, and there is a good cortex, sir.
Appears to be normal size.
Appears to be normal size, good cortex, and with moderate dilatation of the pelvic calyceal system, and
no mass and upper ureter.
No mass, no stones, no mass, and upper ureter not seen.
All right. What about
Pawan,
the left kidney?
shape, size, parenchyma, cortex thickness, corticomedullary, ecos, sinus ecos,
and the outline of the kidney,
ecogenicity, all things have to be told. Now come back to the previous ultrasound. Keep your diagnosis, right kidney. The diagnosis which you have kept, which diagnoses are ruled out from this ultrasound?
Sir, the differential diagnosis of renal calculus and renal mass and renal renal mass and renal calculus are ruled out, sir.
PUJ was your diagnosis. PUJ,
so renal mass was at the bottom,
and right
which
side
is ruled out.
Yes, sir.
Which is ruled out.
Also, no? One of the DD.
Yes, sir.
Do you think there is a PUJ?
No, sir.
Okay, so PUJ is ruled out.
So what would have been if we had this been a PUJO, what would have been the type of dilatation? You are seeing pelvis.
So there would be proportional pelvis dilatation rather than pelvic dilatation will be more than calyceal dilatation, sir.
Okay.
All right. So show the left side and bladder because we have to go fast investigation because.
So left kidney appears normal in size with a smooth cortex, smooth surface, and with well-defined CMD, well-maintained CMD, sir.
Okay.
And bladder, it appears to be a dilated, distended bladder with.
Bladder is not dilated.
Distended
bladder is
with
distended.
Distended bladder with minimal thickening of bladder wall, sir.
Apart from that, what is more important when you are given a case like this? You are not interested in thickness of the bladder wall.
There is no evidence of dilatation of the ureters. There is no ureter visualized.
So important thing is to say that the lower ureter, especially on the right
appears
side,
to be normal.
does not appear to be dilated.
Dilated.
And there is no other abnormality of the ureter seen in this. Either one of your DD was ureter seen.
Yes, sir.
Okay. All right. So what next you want? She has got a hydronephrosis on the right side. Creatinine is 1.02. And other investigations you have seen. So what next you want to do?
Sir, I would like to get.
Remember one thing, from the list of all the DDs which you have, as you keep on doing investigation, there are certain things which are ruled out. So now what are the things which are left out? Moment only one is left, the investigations are over because now your diagnosis is made. So now what things are ruled out, and at this stage, what things are remaining? So accordingly,
sir,
you can investigate further.
Sir, all the differential diagnosis of renal calculus, PUGO, and renal mass, light ureter, right-sided genitourinary tuberculosis.
Right side, GUTB is
sorry.
remaining.
Yes, sir.
Pawan,
Right.
can this be a stone which is passed out?
Stone, no, sir.
Why?
As the ureter is not dilated.
Yes, passed out stone.
Is it
some sort of vagal dilatation is persisting.
Sir, we need to now shift to the next student, sir. Now Dr. Ajhar will take over. Dr. Ajhar, please put your audio visual on. Yeah.
So we have to be very fast now.
Yes, sir. Yes. Go ahead, sir.
We have to finish the investigation and treatment part. Now, next we have to discuss with Dr. Ajay the treatment part.
What next investigation he will ask or look for? What would he ask for? What investigation he wants now?
Anup, who is there? Now,
Dr. Ajhar, please unmute yourself, Dr. Ajhar.
Dr. Azhar.
Azhar,
hello,
please
sir.
unmute. Yeah, you can hear.
So Dr. Vani is asking, what next you want to do?
We want to do gene expert, urinary gene expert.
Gene expert?
Why?
Yes, sir. RT-PCR.
Is your diagnosis made?
So because there was a sterile pyuria, there was dilatation, there was right-sided hydronephrosis. So we had kept the tuberculosis as part of
can it be a mid-ureteric stone? Because
yes,
that
sir,
will not be seen on ultrasonography.
Yes, sir.
It is very difficult to diagnose. First diagnosis.
You have ultrasonography evidence of the hydronephrosis, and
yes,
we
sir.
have sent AFB. Our report is awaited. What would you do now? That is only, but there are hydronephrosis on ultrasonography. What next investigation is in your mind?
Sir, I like to do a CT urography. CT urogram.
CT urography.
CT urography.
Yes, yes, sir.
All right. CT IVP is there. See, go in a systematic manner. Don't go with the idea that, okay, now this gene expert and all those things.
Yes.
Because
Can I make a comment, sir?
Why
they are missing X-ray KUB?
Dr.
Even
Azhar,
though they are thinking.
Dr. Azhar, sorry.
Yes,
Dr. Chala, please go ahead.
Yeah, just I was wondering that even though they are thinking of GUTB, so why they are not asking for the X-ray KUB plane?
That's what I wanted to come. Why CT urography? Why not an IVU with the standard KUB first? And the radiation part and all those things, exposures in mind, when we are dealing with a female, 32 years.
Yes.
I think this is a debatable IVU versus CT. Gautam point of having a plain X-ray can be seen by seeing the plain CT tomogram film. But keeping in view the time we are having, let us finish with this investigation and then we can ask.
But Dr. Azhar, what Dr. Vani is asking is a very relevant question, and you have to be ready with your answer. See, you may justify simple conventional IVP, you may justify CT IVP, but you must have a justification ready. Because the moment you say CT IVP, we are going to ask why not conventional IVP, why not X-ray KUB, and the moment you say X-ray KUB and conventional IVP, we are going to ask why not CT IVP. So your point should be very clear.
Be ready with the answer.
So now read this CT IVP, and let's go for
there's right side on right side. The kidney shows a fluid-filled cystic lesion. The lesion appears to be thin-walled. Sir, there are two cysts actually, one posteriorly and one anteriorly. They are thin walled.
Show Dr. Gautam, show all the plates whichever are available.
All the films before he comments.
Because
Okay,
then
okay.
let him comment on all the plates put together.
Okay, Dr. Rajan, you notice?
Yes, sir.
You
Yes,
seen
sir.
this? Okay.
Yes, sir.
So this is the last image of CT scan which I have.
And this is a reconstructed.
Is that okay? Yeah.
Yes, sir.
Okay,
sir,
so
on the
now we don't want to describe you the plate by plate. We want your diagnosis.
Sir, there are multiple cystic lesions in the kidney and decreased uptake. There are regions which have decreased uptake. The cortical thickness is normal. The cysts have the cysts are thin walled without any internal echoes. So there is dilated pelvis and ureter on the right side.
Okay. So what next you want?
Azhar, my
Yes, sir.
question to you is: if you see the CT carefully,
Yes,
you will see these hypodense areas are of different types. These
Yes,
are
sir.
not cysts. They're because you asked for CT. Now you
Yes,
can't
sir.
escape from describing it properly. You have to summarize what findings you picked up from the CT in support
These
of
are-
the diagnosis which you kept.
Yes, sir. These are hypodense regions without contrast uptake.
Without contrast uptake. Okay,
Yes,
so what does this mean?
And they are homogeneous.
No, what does this mean to you?
Sir, depending upon the
Okay,
house
I'll
field
give you a hint. Do you think it is a cyst, or do you think it is a dilated calyx?
Sir, it is a dilated calyx.
You have to
Because
be
there's a
sure
cortex
now.
around.
Hmm?
Why do you say it is dilated calyx?
Because there seems to be a rim of cortex around it.
Now, just Azhar, look at the picture which is on the left side and one
Yes,
on the
sir.
right side. Right side,
Yes,
the hypodense mass, which is right over the vessel, is different from the other lesions. Are all these lesions of same type or different type? I'm thinking that this may be what you can say an abscess. Prove me wrong.
Further, you carefully see in which phase all images taken. You might
So
see,
this is the- Yes, sir.
yes. Then only you will able to answer what sir want to ask you.
So this is a corticomedullary.
You want to
phase.
see further?
This
Yes,
one is the
right-sided
corticomedullary phase.
On left side?
See the reconstructed.
Sir, left side seems to be a excretory phase.
Yes. So now and
This is
Now,
also
other,
corticomedullary phase.
one question before you go to the next investigation. When you are seeing that there are multiple cysts, they are not calyces. Why are they not seen on ultrasound? Now there has to be some explanation to that, no?
Yes, sir.
You have seen ultrasound plate, you have seen CT scan plate. Are they correlating? If not, then why are they not correlating? There can be reason for that.
So one reason can be that they are solid lesions. So where their echo texture is similar to that of the renal parenchyma.
No, you think they are solid?
No, sir. No, sir. No, sir.
On one hand, you are saying
Other to make the answer simple, depending upon the Hounsfield unit of these lesions, can you tell us what these lesions are? Whether
sir,
they represent calyx, whether they represent cyst, or whether they are caseous cavities, or whether they are parenchymal abscess. Your diagnosis is tuberculosis. We want to know what we are dealing with.
Sir, if the Hounsfield units are 0, then we can safely assume that it's water. If it's greater than 0, then it could be any fluid-filled caseous material or solid.
So what do you expect is the Hounsfield unit? If you think it is a caseous material, what Hounsfield
Greater than
unit?
1, greater than 0.
It's a
Greater
simple
than 0.
cyst. So what should be the
simple
issue?
cyst, we need for simple cyst, Hounsfield units would be 0. It would be similar to that of water. But if it's caseous, then it would be greater than 0. Sir.
Azhar, can this be asymmetrical calyctasis with urothelial thickening if you see it with some amount of parenchymal collections?
Yes, sir. Because there the cyst, there is a cyst wall. Whatever, there is a wall around the fluid-filled cavity, which has an uptake.
No, Azhar, that keeping in view the ultrasound you had, the CT,
Yes,
now
sir.
we had very clear what we are dealing with, because our post-op management may be different.
Yes, sir.
So but you have to be clear whether we are dealing with the parenchymal lesions, are we dealing with the calcical lesions, are we dealing with some cavities, or we are dealing a mixture of all these lesions. We don't know. So your take on that?
So we are dealing with the cavitatory lesions because the kidney.
Okay, we'll go ahead. Okay, next, what do you want now? IEP has, the CT has been given.
We don't have time now.
Okay. Should I reveal the report, sir, or is it okay to?
Yeah, show the report so that we can
Show
go
the
ahead.
report
Yeah.
now.
Yeah, this is the report, Dr. Ajay.
Can you show the
Because
reconstructed images?
Yes.
The
Dr.
previous
Azhar, we
picture?
had one reconstructed image where you see the ureter. Concentrate on the ureter on the right side and the ureter on the left side.
Yeah.
Ureter is dilated on the right side. Yes, sir. And the lower whole length of the ureter is dilated up to the bladder.
No. We are seeing some, Dr. Azhar, sorry to interrupt. We are seeing some constrictions. What are these constrictions? At the PUJ level, then at the lower end, multiple. What are those? You concentrate on those. What are those? Could it be strictures or the simple, natural constrictions where you normally find here and there?
So it could be the normal constrictions there. At the crossing of vessels, we see constriction.
What about the lower ureter?
So lower ureter is dilated except at the one part where there seems to be a stricture, but I
And
cannot
if you compare the two, the difference is marked.
Yes, sir.
Go ahead.
Yes, sir.
Go ahead.
What next you want?
Azhar, my
yes,
question to you is, let us assume this patient had a creatinine of 2. At that
Yes,
point, what you have done to this patient to make your diagnosis?
After ultrasound.
Yes, sir. We can go for DTP scan. But that
DTP, creatinine is 2. I don't think DTP has any value. You have to be a little more specific because you have not made the diagnosis yet. DTP is not for diagnosis.
Yes, sir.
DT is for quantification of the function.
Yes, sir.
So you
think we have there
obstruction at the lower end?
Sir, we'll go ahead. Okay,
Azhar,
we'll go ahead now. Sir, next we can see, sir, what is the...
Okay,
What
else
you want?
What you want?
What you want?
Sir, can we have his DTP scan so that we
Why?
can quantify her obstruction?
No, why you want DTP scan? Why you want?
Because the kidney was obstructed, because on CT scan there was an obstruction at PUJ and lower end. So
No, I think there's a PUJ is where PUJ looks fairly okay. I don't believe that report.
Just see that you don't find any obstruction there.
Quite okay.
Contrast is going well down.
Perfectly all right. Now tell me, if you think obstruction, where is the obstruction? Is it at the PUJ
because
or
the
it's at
whole
PUJ?
ureter, because whole ureter is dilated.
So is it a lower ureteric stricture?
Lower ureteric. Yes, sir.
So if there is a lower ureteric stricture,
Yes,
at this juncture, what help you are going to get with DTPI just now in making a diagnosis?
Do you do often diuretic renogram for lower ureteric stricture?
No, sir.
And that's why when Dr. Salim Mani asked that when you are suspecting an obstruction and when you see this plate on IVP, what next step you will take? You don't have to send patient for DTPA whether it is a significant obstruction or not on IVP.
Yes, sir. So we'll confirm our diagnosis. Sir, by that time, our cultures might have come. We can
No, simple answer is that when you are doing CT IVP, You can take a delayed plate, give Lasix, and take a 45 minutes prone plate to see whether the contrast is ending or not. The job is over there and there. You don't have to send for DTPA. You are not worried about the function. Everything is fine. So you just want to see whether there is any significant obstruction or not. Obviously, patient has pain. There is a hydronephrosis seen on ultrasound. There is an obstruction. So definitely there is an obstruction. You just want to see how much significant it is.
Yes.
So what next you want to go? We don't have time now. We have to finish it fast.
Sir,
hurry up.
We'll ask for the back-tick reports, sir. Gene expert reports.
No, reports are pending. Reports are pending.
AB is positive. Say, for example, AB is positive. What next you want to do?
Sir, we can start the patient on ATT and do an RGP and put a stent.
Okay, so you want to start AKT and put a stent. Why you want to put a stent?
Because the patient is symptomatic for pain, symptomatic, which means her system is obstructed.
So in short, tell me, when in a case of tuberculosis, when you get a patient with this finding and there is a pain, what are the reasons for pain? Is it because of the kidney which has got cyst and which has got cavities and which has got caseating material? Is it because of the infected material in the pelvic cholesterol system and this? Whether it is because of obstruction, whether it is because of the edema of the lower ureter, and of course the cystitis. There are multiple factors of pain.
But she had an in and off, on and off pain, which was colicky on the right side, which could be attributed to the lower ureter stricture.
So if you suspect other things and if you put a DJ, is it likely that she will improve or she will deteriorate? Because this judgment you have to take, and this judgment we want to know from you, how you will think over it. Every case is not, answer is not a DJ stent.
Yes, sir. Because she has had a colicky pain and which is related to the, which is pointing to the right side. So the pain might get will get improved with stenting.
Now the other thing is that, tell me, if she has a tuberculosis, urinary AB is positive, she has frequency, she has dysuria. What about the lower symptoms? Will it deteriorate if obviously it to be a bladder capacity which may not be good, we don't know, and there is likelihood of cystitis, a lot of inflammatory edema, petechial hemorrhages, like what typically you see in the tuberculous bladder. Now, if you put a stent in this case, do you think that her symptoms will deteriorate or she will have better quality of life?
So her lower ureter symptoms.
And how disturbed is she with the pain? Because she has not taken any medication in the history. In the history, it was there that a pain is there, but she does not require any medication for that.
And there will be stent-related problems now.
Yes, sir.
Stent in a suspected case of tuberculosis can have a lot of problems. See, as an examiner, our job is to find out your thought process, because these are all thought processes which you want to assess. Whether you are given importance to everything, patient as a whole, not just because you see the lower end of the ureter stricture, I will put a stent, I will do this. So there are multiple reasons for pain, multiple reasons for this. You have to treat the patient as a whole. There is a bladder problem, there is a ureteric problem, there is a kidney problem. Now, whether stent is the answer, how severe is the pain? She has got pain, definitely, but she's tolerating. She has not required any medication to be taken. Yeah. Yes. All right. So all this you have to assess. Okay, what next you want to do? What else you want to give?
Sir, one question. Sir, if you are posting this patient for stenting, how you will post this patient, and how you are going to start this procedure, with what findings to be noticed all over, with the scopy and with the retrograde injection of the contrast. What finding you will note in support of your diagnosis? How you will post this patient for your procedure, which you are stenting. But before that, what are the findings you expect, and what are the with endoscopy as well as with the retrograde injection of the contrast?
Sir, on endoscopy, we will examine the bladder, see for bladder changes, whether there are inflammation, see the ureteric orifices.
No, just Azhar, you saw
Yes,
this
sir.
ultrasound of the patient.
Yes, sir.
Ultrasound showed a very well distended bladder, but the patient had a frequency urgency. So what can happen if with are you doing this procedure under local or anesthesia?
Under GA, because
Under GA. Okay.
Yes,
So tell me, what are the findings, endoscopic findings, in support of the diagnosis, keeping in view the bladder wall changes and the orificial changes, which examiners are usually fond of asking?
Sir, there may be orificial changes and the
No,
trigon may be
bladder
inflamed.
wall changes, then orificial changes. They are two separate headings. Okay.
Yes, sir. Yes.
Yeah.
Sir, there will be inflammation of the bladder wall.
You describe these changes from a less severe to more severe.
What are the typical findings in a bladder in tuberculosis on cystoscopy?
Yes, sir. We see,
Yeah, this is a very important question. Almost every examiner will ask this question.
Every
yes, sir,
time.
we see Goff-Full ureters, which are, sir, there is trigonitis, decreased capacity of the bladder wall.
Dr. Azhar,
Yes,
what
sir.
are the areas which tuberculosis usually involves in the bladder? What happens to the trigone? What happens to the bladder neck?
Sir, it's inflamed.
Hmm?
Inflamed.
It is spared. Then why did you say
Inflamed.
trigonitis?
Inflamed.
Inflamed. Is it spared or inflamed?
Yes. Sir, firstly, it involves the dome of the diaphragm. It involves the dome and
Close the dome of the diaphragm most frequently.
Yes, sir.
Ureteric orifices. Yes.
Yes, sir.
So,
Sir is asking
Azhar,
what are
because we
the
are short
typical
of
findings?
Yeah, we are short of time. This is a favorite
Yes.
question for all the examiners. Bladder wall changes and the orificial changes depending upon the grade of severity. Because we are short of time. Sabni sir, please, we'll go move ahead.
We can ask last question. Suppose you have started AKT in a case like this. You have not put a double J stent. Or pain is not there. And so how will you follow up? In follow-up, what things you will keep in mind and how will you follow up this case? Last question, and then we'll wind up this case.
Sir, we'll
And the most
ask for
important
her,
question it is.
sir, we'll ask for her symptoms, fever, and do regular LFTs because she's on ATTs, and
Obviously, we are interested in how you follow up of a right kidney because
Yes,
you are not stent. The pain has disappeared, fever has disappeared. What will you follow up? How will you follow up this right side kidney? This is what we want to know before we wind up this case.
sir, I'll do a repeat ultrasound of the kidney to see if the dilatation has increased or not, or it's the same.
Okay. What else will you do? Okay, so one is that increasing hydronephrosis in the follow-up. Anything else?
Sir,
What do you expect happening after you started antitubercular? This antitubercular treatment you are giving, you are directing at the infection. What about the sequelae of the infection? How do you know what is happening to the ureter, what's happening to the kidney, and what are the methods by which you will know for a period of time that the function of the kidney is not deteriorating because of the cicatrization and other things, fibrosis?
so firstly, the patient might have symptoms if there is fibrosis or cicatrization. She might have symptoms such as flank pain due to
They have abated.
hydronephrosis.
They have abated, but the disease process is ongoing. Any investigation we should do to know that? Ultrasound, you said?
Yes, sir.
Okay, so in follow-up, let us give the answer and then we can wind up. So in a follow-up case like this, you must do urine routine microscopic to see whether pyuria is subsiding or not. That's a most important thing which will give you idea. Any case of tuberculosis follow-up, when you have a pyuria which was sterile, whether it is coming under control, ultrasonography. Then most important thing is that a previous lower ureteric dilatation which was not there, whether it is appearing or not. Then whether symptoms are disappearing or not, whether frequency volume chart, if the frequency was more and the each time warded volume was less at that time, how it has happened in the follow-up. So frequency volume chart, that chart itself will tell you whether she is improving or not, whether bladder is improving or not. And of course, as you said, right side ultrasonography and whatever hydronephrosis, apart from the hydronephrosis, what cavities and what they are showing, whether it is increasing or not. The answer, the question which I asked you, why it is not seen on ultrasound and why they are seen on CT IVP, the answer to that was that ultrasonography is a dynamic investigation. One single plate is never representative. So if you have the cavities in some different parts, unless and until you show, you do it yourself, or it is a dynamic film which is there, you will not be able to diagnose everything what is there in the CT scan. So that we were expecting that as an answer. All right. So I think this was a fantastic case. There were a lot of learning points from this case. I must congratulate for selecting this case. The typical findings on ultrasound, typical findings on CT scan, everything was perfect. So I think a lot of discussion took place and we would have brought some more new points. But as sticking to the time, we stop at this point. Thank you all the students for taking part in the discussion and answering the questions. Okay, thank you, Dr. Azhar. So can we go ahead with the next case?
Yes, sir. So Dr. Gautam, I think you can.
Yes, sir, I'm stopping. Yeah,
you
sir.
want to summarize, Dr. Gautam?
Yeah, you can summarize in 1 or 2 slides your take-home message from the case.
Right. So you can actually give real follow-up or whatever developments.
Yes, sir. We attempted right side degestenting after the three or fourth day of the starting ATT, and we could not place the degestenting, so we placed the antegrade degestenting, and then she did good in follow-up, and her right side, degestant we kept for 6 months, degestant kept for 6 months, and then we removed. After starting ATT, degestant was removed 4 months, and she did good. Although the bladder capacity became small, so still she is manageable, having the manageable symptoms.
Okay.
So that's it. Yes, sir.
Good. Okay. Thank you. Thank you very much.
Thank you, sir. Thank you, all examiners, and once again, all the North Zone Council, sir. Thank you.
So thank you, Dr. Gautam, for wonderful case moderation. So next case will be by Dr. Umesh, and currently we are being watched by more than 500 delegates on various platforms. So that shows the interest. That shows the interest in this program, all because of the students and our teachers' efforts. So let's start the second case, and the first student will be Dr. Deepak. So Deepak, please keep your audiovisual on.
Yeah, good evening once again, sir. So am I audible?
Yeah, Umesh, present the case.
Yes. So now I think my slides are visible.
Yeah, we can see your slides.
Yeah.
Okay.
Yes.
So who is the student, sir?
Dr. Deepak.
Dr. Deepak.
Deepak, say hi. Yeah, okay.
Hello, sir. Good evening, sir.
Okay, Dr. Deepak. So should I start?
Yeah, go ahead.
Ready? Okay. So this is a 52 years female resident of Delhi. She presented with pain in right flank for 9 months and a lump in right flank region for 1 month.
Can we stop here to find the candidate? Because this is straightforward symptoms. Chief complaint.
Who is the student?
Or shall we stop here?
Yeah. Where is the candidate?
So anything next you have, Dr. Umesh? What is the next slide?
I have detailed history of pain and lump in next slide.
Okay, so let us ask Dr. Deepak, and then you give the other details. So Dr. Deepak, with this, what more elaboration you want? We discussed right side flank pain in detail in last case. Let's not unnecessarily discuss that. All those things which we discussed about the aggravating relieving factors, type, severity, whether it is colicky, dull aching, everything should be asked for. Now, she also is complaining of noticing a lump in the right flank. So anything more you want to know about details of that from the patient? She has noticed a swelling in the right flank pain. Right flank. So Dr. Deepak, what things you will ask for?
Sir, any associated symptoms like hematuria?
No, any details about lump? She's saying that there is a swelling on the right flank. So you want to know any details about that swelling?
Sir, any change in the size of the lump which she has noticed, or
what else?
Progression and
what do you mean by progression?
Whether she has noticed any changes in the size of the lump.
Okay. What else?
Then, sir, any associated symptoms like hematuria?
Okay.
See, when there is a lump, when patient notices a lump, there are many things which you need to ask for. First and foremost is that how it started, how she noticed, when she noticed. Then this is a very short history. Over 1 month, how rapidly it has increased. Okay. Whether in between it decreases in disappears or not, whether it is progressively increasing. Then with the lump, are there any associated features? Whether pain has increased in last 1 month since the appearance of the lump, whether there is any additional symptoms which has appeared after the lump has appeared for last 1 month. So these are the details about the lump which you need to ask for. The important negative history, hematuria, everything is perfect. But when the patient comes and they give you the presenting complaints, then you have to first focus on the presenting complaints. Once you finish the presenting complaint details, then you go for the important negative history, like you are saying the hematuria and all those things. Okay, so go ahead. What else you want to ask for?
Deepak, one quick question to you. These two symptoms, these two complaints are, I think, what you can say, conveying a lot of messages. If you have to take at this face value of these two complaints, what diagnosis immediately came to your mind? That, okay, I am having this pain and now this right flank mass is there. Now you know this is right flank mass, you know the site of organs placed in the right flank mass, and you know from the pathology that what type of masses appear, congenital, neoplastic, inflammatory. So what came immediately to your mind after seeing these two complaints?
It can be a neoplastic mass or a cystic disease.
Okay, what else? We don't know. Can it be inflammatory mass? Can we have?
Sir, they don't generally present so rapidly, sir. Like the lump has presented in 1 month.
Okay.
It's 9 months. 9 months.
We have just not gone into history of parental illness. We are assessing your knowledge with these two complaints. Immediately, what struck your mind that what I am dealing with, because it is very focused complaints.
I think what Dr. Chawla is saying is very important. Just don't get carried away by the neoplastic. It is a mass. That means it is a cancer. Don't get carried away. This is exactly what he wants to ask you, that what are the different ways? It could still be inflammatory, it could still be stone disease, it could still be congenital problem, it could be cystic problem, it could be PUJ which is causing this problem.
Yes, it will be PUJ. She may be having
a stone, now it has become hydronephrotic. Everything is possible in a common way. And then accordingly you have to ask. Don't just get away, lump, okay, now it is RCC.
So that is the message. That is exactly the message. Yeah.
Right. All right. Go ahead. What do you want to ask? You want to ask hematuria. What else you want to ask?
Sir, any systemic symptoms?
Oh, you tell. What? Don't say systemic symptoms. You just enumerate what.
Which
what you
constitutional symptoms you are talking about? Which constitutional symptoms you are talking about?
The history of weight loss, any bony pain, any breathing difficulty. And,
Okay. Okay. What else? Quick, because then otherwise we have to end up hurry up at the end.
Okay.
Is there any history of past lithuria? Is it important?
Yes, sir, it's important, sir.
Yeah. Is there any history of pyuria? Is that important? Is there any history of lower urinary tract symptoms? See, like we discussed in the last case, there are group of symptoms. Whether you want to ask all symptoms related to UTI, whether you want to ask all symptoms related to chronic renal insufficiency, whether you want to ask all symptoms related to cystic disease, whether you want to ask all symptoms related to stone disease, everything should come one by one, then all symptoms will be covered. There is no confusion. If you go in a systematic way, there is no confusion. If there is a stone disease, then what symptoms you want to ask for?
Sir, symptoms of like previous episodes of pain and
good, very good. What else?
And sir, any history of instrumentation?
Any previous surgery? That is what you want to ask for?
Yes, sir.
Yeah. What else? Any history of lithuria?
Yes, sir.
Any history of opposite side pain? Okay. What else you want to ask for? Or Dr. Umesh, you just show what are the positive histories, negative histories. You can go ahead and show that.
Yes, sir. Yes, in next slides, there is a history of present illness which shows the patient was apparently well 9 months back when she experienced mild dull aching, intermittent pain in right flank region. Pain was usually subsided by taking painkiller, but was not associated with eating, position, nausea, vomiting, or fever. Gradually, pain increased in intensity and became continuous for last 15 days. She also palpated a lump in her right flank region while bathing 1 month back. The lump was initially of the size of a palm of her hand and gradually increased to double of its size now. So, negative history, should I say negative history?
This is how you should elaborate the history. It is a perfectly written history. And if you ask for such thing, and if you present in such manner, the examiner will not ask you anything. He will straight away go next, because he knows that you have already asked for everything. This is exactly how the history should be presented. Yeah, go show the next.
So next, the negative histories are: there is no history of hematuria, pyuria, lithuria, fever, or lower urinary tract symptoms. No history of any trauma in the past. No history of any jaundice, edema, weight loss, melena, or rectal bleeding. There is no any lump in the neck or inguinal region. There is also no history of any headache, backache, chronic cough, hemoptysis, bony pain, seizure, dyspnea, jaundice.
Okay, so what else you need to know? They have given almost everything. So do you think that anything else is remaining?
No, sir.
So how do you ask the important negative history? There are a few causes which come to your mind, and that is how you start elaborating on the history. All right. So what causes have come in your mind just to ask for the symptoms? You think, is it a polycystic kidney?
It can be, sir.
What symptoms you will ask for?
Like hematuria and like changes in this size of the lump. Then they have asked for the jaundice in this case, and
So they have asked for, that's okay, but what else you will ask for?
Do you think this patient is in renal failure? If you
No, sir.
suspect polycystic kidney and one side kidney is palpable, other side is not, or it may be palpable, but patient has not noticed, then do you think this patient is likely to be in renal failure? Okay, so go ahead and next, Dr. Umesh.
Next, we have the rest of the history in treatment. Almost all are negative. There is no as such significant personal histories. She is she is vegetarian, normal sleep, appetite normal. She is post-menopausal female. Family history is not significant. So this all I have in the history, sir. Anything you want to know, I can tell him.
And he will tell it once he has a differential diagnosis. What is your differential diagnosis, Dr. Deepak?
Differential diagnosis is a neoplastic disease.
1, 2, 3. Let us have 3 and then go ahead with each one by one.
No, don't say only one diagnosis.
1, 2, 3.
It's a first differential malignancy. Then
okay, what else?
Cystic disease and
Polycystic PUJ. Is 2. But 3?
PUJ obstruction, sir.
PUJ obstruction. 4.
Why not stone? Why not hydronephrosis?
Yes, sir, it could be a possibility. Stone with hydronephrosis.
What do you think is more likely? Is it a polycystic more likely or stone disease more likely? From the history, of course, we have not examined this from the history.
So stone disease is more likely.
Why? Why do you say that?
The age of presentation is little early in polycystic disease.
Yeah, age can be anything. This is a typical age for even polycystic. Because polycystic you kept as a second diagnosis, so that's what I'm asking. So 52 fits into the polycystic also. Age will not differentiate. Anything else? Okay, let us give him examination and then come to the differential again.
Deepak, how the stone will give rise to a palpable mass in the absence of hydronephrosis or very gross hydronephrosis? How can stone give rise to a mass? You would have seen many cases of stone, a large pelvic, large scrovoid. You won't have seen these patients with the palpable lumps. So how the stone disease present with the lump, which is progressive?
In short, answer what are the reasons of formation of a lump in a case of stone disease? What are the different reasons?
Okay, you should know this, but we'll go ahead.
Yeah, I think so. Let us give examination findings.
Yes. So on examination, general examination, patient was okay, well oriented to time, place, and person. Build is 50 kg. His vitals are normal. ECOG is 0 and KPS is 80. And she doesn't have any pallor, icterus, clubbing, cyanosis, pedal edema, or lymphadenopathy. And rest of the systems are within normal limit. Next, on per abdominal exam.
Umesh, 1 minute, we'll just hold on. We'll ask Deepak only. Deepak, keeping in view the diagnosis which you kept, targeted physical examination, what you are looking?
Any specific things you want to
quickly
ask for, you will provide.
Yes.
You will provide. This is a case of a lump. So what things you want to know from in a case of a lump on examination?
The characteristics of the lump, like size.
No, we'll go to the examination of lump later. In the physical examination, in relation to your diagnosis, which you kept 1, 2, 3. Anything specific you want?
Sir, like pedal edema, which they have already mentioned, there's no.
Okay. What else? Okay.
Stress and.
Why should you should expect pedal edema in a lump?
Sir, because of if there is a renal malignancy can involve inferior vena cava and cause.
How does it involve inferior vena cava?
By formation of tumor thrombus.
Okay. What are the other reasons of having a pedal edema?
VC compression.
Can this be associated with a kidney harboring a stone and the patient is having renal failure?
Yes, sir.
Can this be a part of a polycystic kidney with a renal failure?
Yes, sir, it can be.
No, our point is to just, you should keep in mind the specific findings and their relevance to your diagnosis. This is important. There are a number of other findings, but we'll go ahead because we have less time. We'll come to the local examination.
Yeah. So anything specific you want to know in local, he will tell you.
The characteristics of the lump only.
No, you tell characteristics. See, these are all wrong wordings. Characteristic means you ask for it. No? It is not our job to find out what characteristic. Now, next question is what characteristic. It's a waste of question. You tell us what you want. You want the size. You want to what things you want to know from the lump examination.
The size, surface of the lump, then
size, surface. Okay. What else?
Moves with respiration or not. And,
okay.
Blood level.
Any dilated veins on the abdomen, sir?
What else? See, dilated vein is not a lump examination. We are now focusing on lump examination. There are many things about a lump. Finish that. Surface you have said. Moving with respiration you have said. Size you have said. What else? There are so many things which are remaining.
Yeah, so many things are there, Deepak.
Yes, sir. So any local rise of temperature or tenderness to rule out?
Yeah, okay, that's very good. So first and foremost is the tenderness. Any lump which when you examine, whether there is a tenderness present or not. What else?
So we can shift to the next student. So we can shift to next student now, sir. Dr. Mukesh. Dr. Mukesh can take over now.
Let's ask the next student and then let's go fast.
Hello,
so
sir.
Next student we ask for the examination, duty and investigation, and then the third student will discuss about the treatment.
Yes, sir.
Who is the next student?
Sir. I'm here, sir.
Okay.
Dr. Mukesh, sir.
Dr. Mukesh.
So Dr.
Yes,
Mukesh.
sir. Yes, sir.
Okay. So we were on the examination of the lump. So he said that
Yes,
it is moving with respiration, surface, size. What else you want to know?
Sir, first we want to look for local temperature and tenderness, movement with respiration, consistency of the mass, and margin either margin of the mass either is well defined or poorly defined.
Very good.
And tenderness at the renal angle, sir.
Perfect. So these are the things which you want to know.
Yes,
renal angle fullness. See, any lump, obviously in a urology, it's a kidney lump. Nobody is going to give you other things. So local temperature, tenderness, and renal angle fullness. These are very, very important things. If it is a non-kidney, the renal angle fullness will not be there. Okay. If there is a lump of a kidney, rising of kidney, renal angle will be full. Then go in a very systematic way. Surface, size, first and foremost is size.
After you see the temperature and tenderness, now size, how do you describe size of a right side flank lump?
Size, sir, we will look for, sir, either mass is going subcostally or not going subcostally. Then they measure the upper limit of the mass and lower limit of the mass.
How do you know upper limit of a kidney lump? Can you examine the upper limit?
For kidney, sir, no, sir.
It's not possible. So in a kidney lump, in a lump like this, the size means what it is, how many centimeters beyond the costal margin. This
Yes,
is
sir.
what implies the size, and whether the lump is crossing the midline or not. When you, what do you mean by size? You want to know the extent of this lump. Examiner, without examining the patient, should understand what you are saying. So if you say that the kidney or lump which has extended 4 centimeters beyond the costal margin and it has not crossed midline, I have understood where exactly the lump is situated. All right.
And we
So
have, and one has to understand and differentiate by the examination whether we are dealing with a renal lump or the colonic mass, or is it separate from the liver? Is it bimanually palpable? Is it palatable? We should understand from the examination only what we are dealing with. Are we really dealing with a renal mass?
Yes.
Okay, so I think these are the things which are important: surface, margin, consistency, mobility, movement with respiration. This should come automatically in a fraction of a second. All right, so show the details of examination.
So on per abdominal examination, on inspection, abdomen is scaphoid, no distended veins, no scar mark, umbilicus central inverted, skin normal, hernial orifices intact, external genitalia is normal, renal angle is normal. On palpation, there was a single firm on-tender mass of 8 by 8 centimeter in the right lumbar region. Extent of tumor bimanually palpable. Surface irregular. Mass was not fixed with the overlining structures and moving minimally with respiration. Right renal angle was full. Mass did not fall in knee elbow position, and there was no other organomegaly.
Okay. All right. So you're happy.
Interpretation of this mass.
Anything else in the examination? Finish the examination so that we can go ahead with the DD.
Yes. On percussion, tympanic note found all over the abdomen except the mass. Right angle was dull. Auscultation, no added sounds was there. And in PV and PR was normal finding. No vulvar edema was found.
Okay, so now symptoms and the examination is over. Now you come to DD.
Sir, my first DD is, sir, solid renal mass.
Okay.
And second is cystic renal mass.
Now, why did you say solid renal mass?
Sir, at this age, sir, cystic mass is, sir, less commonly presentation. PUJ is presented at this age with incidental diagnosis, sir.
No. The question is, how did you say it's renal mass, solid or cystic? How did you got to know from the examination finding?
Sir, on percussion, there is a dull note, sir, over the mass.
So cystic mass will not have dull note?
Sir, there is a fluid thrill, sir.
Fluid thrill?
Not
Okay, Mukesh, come to the differential diagnosis.
Sir, first is renal mass, that is neoplastic, sir. Second is...
No, be specific. So neoplastic renal mass, most likely what? I'm not going to ask you. So whether
RCC,
it is a...
sir.
So say that it is likely to be renal mass, likely to be RCC.
Yes,
all
sir,
right.
RCC.
Nobody is going to ask you what are the details and what histological thing. But in a lump like this, it is most likely RCC. All
Yes,
right.
sir.
What next? Anything else in your mind?
So there's the cystic autosomal dominant polycystic kidney disease second, sir. Third is PUJO, sir. Fourth, maybe renal calculi and hydronephrosis.
Why can't it be any other retroperitoneal mass? Why can't be a large adrenal mass?
Sir, there is Ballotability presents, that is characteristic of the renal mass, sir.
Renal mass. Okay. So do you get, suppose if it was an adrenal
Not
mass.
ballotability is not written, it's written bimanually palpable. Ballotability is not written in the examination.
It was bimanually palpable only.
So do you get ballotability in the adrenal mass? Suppose if it was a big adrenal mass, or say for example in a child you get neuroblastoma, quite often you get confused. Is it ballotable or it is not ballotable?
It may be, sir.
No, it may be nahi. See, you have to understand. So this means that you are not sure when the ballotability comes and what is the reason of ballotability of a mass. When the mass becomes a ballotable. What do you mean by ballotable?
Ballotability means, sir, when we palpate the mass from posteriorly and one hand we put on the anteriorly, and then we push the mass from posterior hand, then we feel on the anterior hand, sir.
Okay. So that is what is a ballotability, that you, if you push the mass from the back side, it moves and comes to on the anterior side where you can palpate it. So
Yes,
when the ballotability comes, any lump which has got a pedicle, that will become ballotable. Any structure which has got a pedicle. So a kidney has a pedicle and therefore it is ballotable. Adrenal doesn't have a pedicle, no? So it will never be a ballotable mass. Okay.
Yes.
All right. So how will you proceed? Let's go for investigation.
Sir, I will go
Mukesh,
for routine.
Mukesh, before you go
Yes,
for investigation, keep in mind there are two types of investigation. One directed towards the diagnosis and other directed towards the general investigation and then going for the other imaging findings. So make sure how you are going to proceed now, because this diagnosis is almost, you have got a lump, you have got a pain.
Yes, sir. Sir, first I will go for a CBC and a urea creatinine. Then I will go for USG volume.
Go for you.
Yes, sir.
So show CBC, creatinine, show all this. Whatever you ask for, you show.
These are the investigation. CVC hemogram is written. It's normal. And creatinine is 0.9.
Okay, what next?
Sir, USG whole abdomen, sir.
USG whole abdomen. Okay.
Yes.
You don't want urine routine microscopic? Is it relevant? It's not relevant?
Sir, we can go for, sir, for there is either pyuria or hematuria is present in routine microscopy, sir.
No. Whether you want to do urine or not. See, remember,
given,
in
sir.
urology case, never bypass urine routine microscopic. This is the
Sorry.
tip we want to give. Now, in this any urological case, there is bound to be some relevance. In this case, patient has not given any history of hematuria. You have a mass which is big mass, and you want to see whether there is any microscopic hematuria or not, whether there is any the pyuria or not. So these things will be important. So urine routine microscopic is important. All right. So urine is done, and now you want to do ultrasound. Okay, go ahead with ultrasound.
Save time. Can you
Read
give
all,
him the
read
finding?
all the 3 films. Try to see all the 3 films, concentrate, and then come to.
These are rest. I have one film.
Yes. Okay. This is bladder picture. Okay.
So for the sake of time, can we give him the findings, sir? Because
Why
time
not?
is less.
Okay.
Yeah, let's
Okay.
get your findings so we
Better.
have full discussion.
Okay,
Okay.
better.
Ultrasound finding.
Yes.
So ultrasound whole abdomen, liver. There is a right kidney 9 to 9 centimeter heterogeneous eco-texture mass in the mid and the lower pole. Actually, sir, this finding has a color Doppler also. So it shows a thrombus in the right renal vein extending to proximal intrahepatic part of IVC. with internal vascularity. And the diameter of renal vein is 10 mm and IVC is 40 mm. And at the confluence of hepatic vein, IVC is normal in caliber and shows normal flow.
Okay. What next? What next, Mukesh?
Yes, sir.
Next you want to do?
RFT is normal. It is given to you.
Creatinine is 0.8, no? How much is creatinine?
0.9.
0.9. So what next you want to do?
Sir, in this case, sir, for metastatic workup, sir, I will go for chest X-ray.
Metastatic workup or diagnosis for what?
But you don't want to do the primary workup?
Primary workup, primary staging?
Or
Diagnosis is what?
So job is over.
This is ultrasound and color Doppler. We have not. This is not a contrast color Doppler.
So, okay, sir. I was confused with this scan, sir. I will go for CCT abdomen, sir, with triple phase contrast, sir.
Okay.
Okay.
So show that triple phase contrast CT IVP.
Sir, yeah. I will show all the films, sir. I have 4 or 5 films.
Yes. Please go ahead.
Show all the plates and then you can interpret.
This all I have.
Okay. So what things you want to know from the triple phase contrast CT scan?
Sir, first, sir, in non-contrast image, I want to know that there is a mass. What is the size of the mass?
You don't want to have separate non-contrast, contrast. Overall, whatever investigation you advise, what things you want to see?
Okay, sir. Sir, size of the mass, sir. Either
Okay.
it's taking contrast uptake of the mass, sir.
Okay.
And
What else?
then is the either necrosis or calcification present in the mass.
Okay. Okay. What else?
And the renal vein and IVC status of.
Okay.
And lymph node status, sir.
Okay. What else?
And for metastasis, liver status, sir.
Okay. What else? What else?
More important.
Yeah, ask for triple phase contrast. What else is more important?
Opposite side kidney, sir.
Opposite kidney is okay. What else? What is more important in a case like this when you have a big lump which is palpable, which is hard, irregular surface, very less movement with the respiration? What do you want to see on CT scan?
Sir, TNM staging of the mass, extent of the mass, sir. Either T1, T2, T3 staging of the mass, sir.
Yeah, so that is very, very important. All your CT scan is going to tell us what is a T stage, whether it is adherent to the surrounding structures or not. What about the adrenal gland? What about the liver? Whether there is a fat plane which is separate or not. If it is a lower polar mass, which is a big mass, what about the bowel? Whether it is involved or not, whether there is any obstruction or not. If there is a thrombus, what level is a thrombus? To what extent it is going? What about the IVC below the renal vein? What about the renal vein on the opposite side? These are all things which are important for you when you ask for triple phase contrast CT. All right.
Okay.
Okay, now tell us the report and then we can discuss further.
In report, there is a large mass of 9.5 into 9.2 into 7 centimeter mass in mid and lower pole region of the right kidney. Mass shows enhancement with few areas of necrosis. Large enhancing thrombus is seen in right renal vein extending into the intrahepatic segment of IVC, 2 centimeters below the confluence of hepatic vein. Few enlarged non-necrotic lymph nodes in the retrocaval region at the level of the renal highline. Left kidney is normal, bladder is normal.
All right. Okay. So now anything else you want to know? Any further investigations, or you are happy now?
Sir, I want to do, sir, for metastatic workup, sir. For that, I want for
what workup you want to do?
Chest X-ray posterior anterior view, sir.
Chest X-ray.
Yes, sir.
Why you want to do X-ray chest? When you have a thrombus in the IVC, when you have a large mass like this, when you have a multiple big size lymph nodes in the area, is X-ray chest sufficient? Is that the kind of workup which you do?
Sir, in this case, sir, lymphadenopathy is present, sir. So indication is for the chest X-ray, chest CT scan, sir.
So obviously it is a chest CT, not the X-ray.
Yes, sir. Chest CT, sir.
So you have to be very clear in your mind how you are going to investigate. So there is absolutely clear indication for CT chest in this case. All right.
Yeah.
Do you have CT scan?
So what is the Mukesh clinical stage? Where does it fit now? Can you make the clinical CT free? A, B, C, what? N0, N1, or M which stage? The liver is normal, the bones which are appearing in the CT are normal. Can you stage it?
Chest CT, is it done? So then we can ask him the stage.
Actually, sir, chest CT was not there. We have chest X-ray only.
Chest CT is normal. Okay, consider chest CT normal. No metastasis in the chest.
Sir, T3B, N1, M0.
T3B.
So when you have a T3 disease, you need to have a CT chest, not X-ray chest. So that is important. That was the message he was conveying. Okay.
Yeah. Yes.
Why do you say T3B?
Sir, renal vein thrombus is going up to below the diaphragm, sir. Going below the diaphragm and in intrahepatic region, sir.
Okay. So when do you say it is T3C?
Sir, if thrombus is going above the diaphragm, sir.
Okay.
Or involving sinus or going perinephric fats.
All right. Now, if you want to really see the upper level of thrombus, which is going to make a key difference or key thing when you are planning for surgery, because this patient doesn't have any metastasis anywhere. So if you want to see, are you happy with the CT scan to see exact level of the thrombus, or you want to know something more?
And what investigation will be that?
Sir, in CT, Kalikrat mentioned that level of the thrombus is there is any confusion in CT scan, we can go for the MRI, sir.
Good. Okay. Anything else you want to do when any other thing which you think you will be better off with MRI in any other finding? Or any other thing?
Sir, if patient has CKD disease or allergy to the contrast,
we are discussing this only.
Any test which will be more helpful now.
What about the T3C? It is not only the thrombus above the diaphragm. Suppose there is a IVC invasion.
Okay.
What would be the stage?
T3C, sir.
So T3C is above the level of the diaphragm, the thrombus which is going, or the IVC invasion. Now, how do you make out IVC invasion? Which is a good investigation to make out IVC invasion?
So MRIs.
So when there is a suspicion of IVC invasion, MRI will have more relevance. It will tell you in a confident way whether there is an IVC invasion or not. Otherwise, to find out the level, CT scan is fair enough to see the IVC level. Okay.
So continuing the same question, Mukesh, what are the findings in CT predict that vena cava invasion may be there?
Okay, sir. Sir,
predictors of caval invasion based on the contrast Doppler or the CCT finding which you have?
Sir, first is the size of the mass, sir. Larger the mass.
No,
and
it's not the size of the mass. It's not. If you know,
nothing to do with the IVC invasion.
Otherwise, we'll go ahead.
So that question is very important. When do you suspect the IVC invasion? See, IVC invasion will upstage the whole disease.
Sir, now we can shift to next student. Dr. Vikas can now come in.
Yeah,
Put your
so
audible on.
let me ask the last question and then we'll go ahead with the treatment part with Dr. Vikas. So last question, you answer this. How do you, what Dr. Chawla has asked, when do you suspect the IVC invasion? If you don't know, then we'll go to Vikas and ask him.
Don't know.
Okay, so
Mukesh, one more thing which I want to know. Just look at the thrombus. Look at the thrombus. Look at the contours of the large vein, which is the vena cava. How do you find this thrombus to be? Do you find this type of thrombus when you see the RCC with the venous thrombus into the IVC, or do you think it is looking different? Is this the typical type of thrombus you see? You are seeing the pictures, what has been put by Umesh? You just have a look at this.
Yeah, the picture.
Look at the kidney, look at the mass, look at the thrombus going, and look at the way it is going. Is it being seen as a cast? No. So what is your views about this thrombus especially?
So there is no well-defined IVC, sir. Whole of the IVC have, sir, engulfed by the mass, sir.
No, that is IVC is full of thrombus. But I just want to know from you the character of thrombus. Do you see this type of thrombus, or you see a different type of thrombus? Are you happy with the appearance of this thrombus in this patient? Because you are planning an intervention now. If everything, the following investigations are okay, patient will need for ask for some treatment. Okay, we'll move ahead. Next candidate.
Yes, sir. I'm here, sir.
Vikas.
Vikas, when you are looking at thrombus, what are the important things you make note of?
Sir, the enhancement of the thrombus, then possible invasion of the IVC wall.
Okay. Okay.
And
what
then extent of the thrombus.
These has been already discussed. Do we have any portal phase or venous phase where we can see the IVC with contrast and the lesion of thrombus in the IVC? Do we have the pictures?
Sir, I have these pictures. Let me show you some axial films.
I think Dr. Chawla, you can just give answer and then we'll go ahead for treatment.
Yeah.
Because now we
see,
are only
just look at the from the say cephalic to caudal, and you can see in the liver cuts you will see the large dilated IVC, which is a thrombus, and the trickle of contrast going in between the lumen. Usually we see the thrombus showing as a cast. It is cast, and you see the rim of contrast all around that cast. You come from this picture and keep coming down, you see always the trickle of contrast. So this is a very loosely organized thrombus, which is a worrying to me. So, and the IVC is very, you can say enlarged or dilated to the dimensions more than 4 centimeters. So I may be having some areas of invasion. We don't know because we have got limited information from these cuts. But these are the things which are worrying me. So making me little that what precaution I have to take when I am planning intervention for this patient. All these things are important. The cranial extent, the type of thrombus, how is looking like, the arterialization of the thrombus, the presence of contrast all around the thrombus, the lighting up of the thrombus. All these things have some bearing on the operative intervention. Fine.
Okay, so Vikas, you have seen the CT scan picture. Is T3B, CT chest is normal. So what treatment now will you plan?
Sir, I will be planning for a radical
No,
nephrectomy with IVC.
metastatic workup is normal.
Sir, right-sided radical nephrectomy with IVC thrombectomy, sir.
Okay. So what incision you will take? What
Sir,
problems you suspect? How you prepare yourself for this surgery?
So I will be
just 1 minute, sir. Because your plan is correct, but before planning, before undertaking this procedure, what else this patient will have some investigation or some sort of consultation to the other specialties so that you plan well for this procedure.
Sir, we can have a lower limb Doppler, sir.
No, what you will have. It's not we can have. You have this patient in your center. How you manage and how you are.
Will you go solo? Dr. Chawla wants to know, will you go solo or will you take help from someone? And when will you take the help from some other department?
Sir, as in this case, the thrombus is extending into the intrahepatic region, so I will take the help of the liver team.
No, see, because you have to be clear, it is extending 2 centimeters below the hepatic veins. The extent has been given, unless and until the CT is wrong, but this has been given to you. So
So we will be taking the help of a vascular surgeon, sir, in this case.
Okay.
In short,
what this
when
patient
you
will
are
have.
planning this surgery, what steps you are planning? What incision? Where will you put a clamp? What things you are planning? What is there in your mind? How will you go ahead with this surgery?
Sir, I will be taking a chevron incision, sir. Then after opening the abdomen and reflecting the ascending colon, I will be incising alongside the cecum and up to the root of the mesentery, then reflecting the whole of the bowel over there. And then I will first mobilize the liver, sir. The liver will be mobilized by incising the coronary and the triangular ligament, and medial mobilization on the vertical axis of the liver will be done. After that, I will try to isolate the renal artery and ligate it, sir. After ligation of the renal artery, then I will proceed with the IVC. In the IVC, I would like to mobilize the IVC, and then the clamping will be a sequential clamping. First, the clamp will be.
So where will you
because I'll interrupt you. Because I'll interrupt you.
Yes, sir.
Because I'll interrupt you. Why? Because I want you to tell us what is the principle of managing a RCC with IVC thrombus. After incision, what is the first step? What first? You have described many steps before a key step.
Sir, mobilization of the liver, sir.
No, where mobilization of the liver? What is the key step? Which structure has to be ligated first?
So renal artery, sir.
Okay, this is the answer which you are looking for. Now tell me on right side how you will identify and how you will trace the renal artery, right renal artery.
Yes, sir. After mobilizing the ascending columns medially and mobilizing the liver, we will try to isolate the renal artery and in the.
No, we don't go for all this step. We don't go for mobilization. We don't handle the tumor at all. We don't touch at that area.
It is a
big tumor. We have not done anything.
The whole of hilum.
Yes, sir. We'll try to look for the renal artery first, sir.
Where?
In the
Where exactly?
Aorta cable group, sir.
Yes. How you reach intracategory? That is the step I'm asking. If you know, tell. Otherwise, move will head.
Sir, we will mobilize the root of the mesentery up to the foramen. Ligament of teats. Up to the ligament of teats, we'll incise the root of the mesentery, and then we'll mobilize whole of the small intestine over there, and we'll expose the IVC and the aorta over there.
Okay, I'll give you a hint. We have ligated the renal artery now in the intravertebral group. Okay, now what next?
Where will you put a clamp in the IVC? How will you put it? And how will you deliver the thrombus?
Sir, there will be sequential clamping. First of all, we will clamp the lower end of the IVC. After that, we will clamp the contralateral renal vein. And after that, we will clamp the superior aspect of the IVC above the.
Because you stay here only, because now clamping the IVC, we understand that you need to mobilize the IVC. Now, and while doing this, which tributaries of IVC you will ligate?
Sir, I'll first of all the lumbar veins, then the inferior mesenteric veins.
Inferior mesenteric is already over. That was the time when you were looking for a renal artery. That was the time you were looking. Medially, you were going medial to the inferior mesenteric vein, and you were going ahead, splitting the peritoneum and just going to the artery straight and clipping it. That is over now.
What will come near the liver? What will come there when you are just near the liver, taking it up?
You have ligated the lumbar vein, yes.
The gonadal vein, sir.
Yes, if it comes in your way, you will ligate. Fine. What else? Keep going up. Keep going up.
Up. Important there.
Adrenal vein, sir.
Oh, where you will see adrenal vein?
Sir, adrenal vein.
You are not going into the gerotas. This whole thrombus with the radicalfectomy specimen will come intact.
Something around the liver.
Okay, tell me now the clamping order. We have tied all the veins which we wanted you to tie. You have ligated, and now tell us the in this patient with the thrombus 2 centimeters below the hepatic vein, your order of clamping.
So the inferior portion first, the inferior IVC, then the contralateral renal vein, and the superior aspect of the IVC above the thrombus.
Okay.
All right. So
and
if you have,
let us assume this patient had thrombus at the level of hepatic vein.
Yes, sir. So for that, the clamp will need to be applied above the hepatic vein, and for that I will need to do a Pringle maneuver, sir, to reduce the blood flow to the liver. Sir.
What do you want to
Pringle
do?
maneuver, sir. So Pringle maneuver, sir.
So if the thrombus is up to the level of the hepatic, where will you put the clamp on IVC?
Sir, above the hepatic vein, sir.
So where? Above the diaphragm, below the diaphragm?
No, below the diaphragm.
So
how you will put this liver is so big organ, where you will put the clamp?
Sir, we'll mobilize the liver completely.
Okay, tell me how you will mobilize the liver.
You have to mobilize, put the liver down, push the liver down, and go up to the IVC, where it is entering the diaphragm.
We will divide the coronary ligaments, sir. We will divide the triangular
ligament.
ligament.
If you have to divide, to mobilize the liver, there is an order of going to the various ligament to do this procedure, which is rolling back of the right liver to the left, a piggyback maneuver. Can you name the ligaments in order which will be excised to do this step?
Sir,
okay.
Triangular ligament, coronary ligament, and then falciform ligament.
No, the first ligament which comes, you can't reach falciform first. So it will be teres, ligament teres, falciform, right coronary, right triangular, then again go to the left side, the left triangular. Then you will mobilize, then do Pringle maneuvers, then you will have a suprahepatic clamping of the IVC.
Okay, you were telling about the clamping, the sequence. Why you want to have that sort of a sequence? Let us discuss only principles. We don't want to go into the details because that may not be expected from you. So why you said that this is the way you want to clamp it? And how do you want to release it?
Sir, the release will be first of all the lower side of the IVC to flush any air which is there inside to prevent any emboli. Then after that, we will release the superior aspect of the IVC, and we will see if the IVC is in control, it is not bleeding. Then after that, we will release the contralateral release.
What is the principle behind all these principles of having order and this and that? What is the principle?
Sir, in the release principle, the lower aspect is first of all released because to prevent any air embolism.
Correct. So it is because to prevent any air embolism. All right.
Yes.
What else?
And then we followed this by the release of the superior aspect to have a proper IVC control so that there is no bleed from the IVC.
Okay. Now tell me, when you are mobilized the kidney, you have put all the clamps, and now you open the renal vein and IVC, and you are delivering the thrombus. Now, when you are delivering the thrombus, you find that at some place, actually it is adherent to the IVC. It is probably the IVC invasion. Rest of the IVC is clear, but at some places you think that it is not coming out. It is stuck to the IVC wall. So what will you do?
Sir, we will have to dissect that segment of the IVC, sir.
You will have to dissect and do what?
Sir, excise that segment of the IVC.
Excise that segment. So how much segment you can excise?
So nowadays we have PTFE grafts, so we can excise around 45 centimeters.
Okay. So the principle is that if you can excise the IVC part of the IVC wall, and if the half of the lumen is still is manageable, there is no need to put any graft or anything. But if you are excising the whole width or the significant part of this, then you need to have a graft. Okay.
Because let us assume this patient had a left renal mass with IVC thrombus. Then how would you manage?
So the principles will remain almost the same. Only part between right and left is that we on the right cases we can excise the IVC and we can leave it because left side we have
no excision of IVC is not coming. We are just leaving yourself to a thrombus which is not infiltrated the IVC. It doesn't need any resection. We are just asking the management of a left RCC with the thrombus going to this level only.
It will be the same, sir. The management will be the same.
Please specify how you will.
Sir, we'll begin with the clamping of the renal artery.
Okay. Okay, we skip that. Tell me the order of the clamping of the IVC now.
So the lower aspect of the IVC, the contralateral vein, followed by the superior aspect. Followed by the superior aspect of the IVC.
And before that,
we will have to ligate this adrenal vein and the gonadal vein as well.
No. You are going off tangent. Adrenal vein should not come to your. Adrenal vein has no business today here now. We are talking about the same order of clamping, but on the opposite side. We have put a infrarenal clamp on the IVC. Then we are looking for second. Then we are looking for second clamp is where?
Superior aspect of IVC.
What about the renal artery and vein will be like this only?
Renal artery.
They'll be pouring blood.
What is the difference between left side and right side? The main difference. That's what he is trying to ask you. What about the collaterals, anastomosis, and this? How the blood is drained?
In the left side, we have
the difference between right and left.
The gonadal vein drains into the renal veins on the left side.
So we'll move on to the next question. Sir, we'll move on to the next question.
Yeah, I think so. So Vikas, suppose you have done this surgery, you have removed the thrombus, you have done everything, surgery went off very well. And so now tell me, what are the complications of this surgery?
Sir, we can have embolism, pulmonary embolism. Then we can have bleeding. Then,
No, enumerate very quick the important complications because we have only 5 minutes now. Pulmonary embolism is okay. What else?
Bleeding is there, sir?
Bleeding and all is there in every case. Specific. When you have so much of dissection, there is a prolonged paralytic ileus. When you have clamped the IVC for such a long time, there could be stasis and cause deep vein thrombosis and the thrombophlebitis. What else? What is more important? Post-operatively, the important complications. One kidney are removed. What about the other kidney?
We'll have to see for the status of the other kidney, sir. It can
Yes.
go
So
into
what can happen
AKI,
temporarily?
Acute kidney injury can
Yes.
happen, sir.
Yeah. So you can have some AKI in the other kidney. That is possible. You have to keep a watch on the urine output intraoperative as well as in the post-operative period. All right. Suppose this patient, the report is the clear cell RCC and it is a T3B and it is N1. It was a significant low node and 3 or 4 lymph nodes were there. One is involved. So Forman grade 4. So now what next you want to do? Patient has recovered well. He's recovered from surgery, drain is out, everything is out, he's on oral, he's ready to go home. And that report has come. So how will you manage? What advice will you give him?
Sir, we'll have to go with the surveillance protocol, sir. This appears to be a high-risk case. So we'll have to get a CT or a MRI done at 3 months, then 6 monthly interval till 3 years, and then annually till 5 years. And we'll have to get a X-ray chest also according to the same protocol.
Will you give sunitinib post-operative period? Will you give TKI post-op adjunct? What is the concept?
So it is not a metastatic disease.
Hmm. So when you give adjunct sunitinib, which are the cases?
So in cases of metastatic RCC, it is recommended, sir.
Okay, what else?
Then in cases of palliative nephrectomies, when we are doing some
Palliative
nephrectomies. So if the patient has a metastatic disease
or something like that.
So if the patient has a metastatic disease, but he's having too many symptoms because of the renal mass like pain or anything.
That is all right. So that as such you are giving. Okay, what else? I'm asking specifically about such case.
Because he's asking about adjuvant treatment of a high-risk disease. It is localized, locally advanced. It's not metastatic disease.
There is no metastasis.
Yeah. If you know about the evidence and the trials from Prosper, Astrac, Everest, if you can name few trials, he'll be happy.
Sir, we have the Everest, we have the Atlas, we have the Prosper.
No, he was asking about sunitinib. Can you name the trial which involves the use of sunitinib adjuvant treatment?
Current concept of adjuvant TKI.
We have the Assure trial, sir.
So what
which has shown, only trial which has shown some benefit in the as a adjuvant treatment with sunitinib. Can you name that?
Sir, Assure trial, sir. Adjuvant
No,
sorafenib and so.
It's not that, Assure.
Source, sir. Source.
No.
Forget the name. What do you understand from that? Tell us the principle. Whichever, whatever is the name. Have you understood that? What are the principles? What are the current concepts which are changing?
Sir, in cases of high risk cases, they are advising adjuvant treatment with the TKI, sir.
Why is that? Previously, it was very clear that unless you have evidence of metastasis, no TKI. So why it is changing?
Sir, to prevent the chances of recurrence, sir.
Prevent chances of?
Recurrence, sir.
No, they'll never say like that. See, when you are talking of this, you have to see whether there is a disease-free survival and overall survival.
Overall.
You are talking of recurrence and this, that, nobody is interested in that. Whether whether adjuvant TKI will give you disease-free survival and overall survival or not, vis-a-vis the complications. So what are the concepts of that? Other thing where you will give adjuvant TKI is where you are not able to remove the tumor completely, and you know for sure there is a residual disease. Margins are positive. There is some psoas which is infiltrated, and you have shaved off the tumor. Okay. So in those cases, you would like to give adjuvant TKI.
Vikas, one question to you. Any role of preoperative embolization in this patient, or say a little more extensive thrombus?
Sir, it is controversial. Preoperative embolization is known to reduce the vascularity of the thrombus and the tumor. Plus, it creates an edema which helps in the dissection of the tumor. But it is controversial, sir. Some advocate it, some don't, sir.
So if you embolize the patient, when will you do surgery? Will you do immediately 24 hours, 48 hours, 72
After 48
hours?
hours, sir. So 48 hours, sir.
Why
After 48 hours?
Why 48 hours? Why not 24 hours? What is it that happens in 48 hours? See, when you do angioembolization before surgery, there are principles why you want to do angioembolization, the purpose. And depending on that purpose, your duration, when you will do surgery is decided. If your purpose is only to reduce the vasculation, shrink the thrombus, and you think that the artery is encased into the mass and it will be very difficult to find out the artery, then you embolize that, and so that you can you are sure that the vasculature is cut off. In that case, embolize and take immediately for surgery. That is the purpose. All right. Now, when you are doing this embolization, what you said that there are planes which have been created, it becomes, dissection becomes easy and things like that. Then when that happens?
So 48 to 72 hours.
Yes, so that happens because the inflammation takes place, and the benefit which you want, that happens in 24 to 48 hours. You don't want to prolong it further because every angioembolization is going to induce severe paralytic ileus, vomiting, and then patient who is fit will become unfit. And therefore, it's a very dicey situation where at one stage you want to take the benefit of that. At the same time, you don't want the patient to have distended abdomen, vomiting, high-grade fever, and paralytic ileus, and as patient becomes unfit. So for that purpose, 24 to maximum 48 hours is the timeline. All right. Okay, how will you follow up this patient? Suppose you have done everything fine. You said that 3 months you want to do CT chest and CT abdomen.
Yes, sir.
To find out any local recurrence, and if they find out any chest recurrence. All right.
Yes, sir. Yes, sir.
So suppose at 3 months there is a doubtful 1 centimeter mediastinal node on the CT scan, which was not there pre-operatively. How will you go ahead? Local, everything is fine, patient is fine, no symptoms, no cough, nothing.
Sir, we'll go with the FDG PET scan, sir. It has low sensitivity, but specificity is good.
Okay. So there is a node which is present even on the PET, FDG PET.
Sir, if a single node is present, then metastasectomy can be done, sir.
Will you prove that it is metastasis? You assume that it is metastasis and start TKI. Or you want to do biopsy and then start TKI? You want to assume that it is a metastasis and start TKI. What is the principle?
Sir, I want to do a biopsy first because in Indian population we have high positivity, false positivity of the mediastinal nodes.
I think Dr. Anup is signaling that the time is over, so we can start.
Yeah.
Dr. Salim Mani, Dr. Chawla, you want to add anything? Last thing? Or
No,
you want to...
it's fine, sir. Only thing is what we are talking about adjuvant. The same holds true for neoadjuvant. Any role of neoadjuvant for giving a targeted therapy for vena cava thrombus reduction, the mass reduction. That also you should be knowing what is the answer to that.
Yeah,
Then
there are
adjuvant
new
treatment.
concepts which are coming up.
Yeah.
And that if you answer well, definitely that will give you a score more than the others.
Yeah.
Dr.
And
Mani, you want to comment anything on that?
Yeah. I think he has covered most of the things which you would expect from a student at this level, and has done well. And I just wanted to tell him that it is always easier to handle a right-sided malignancy than the left-sided malignancy.
All right. Over to Dr. Anup.
Yes, sir. I think, sir, Dr. Umesh can just show one or two take-home message slide.
Okay,
he has got, I think, one or two take-home message slide. So you can show Dr. Umesh.
Already, sir has covered most of the things. I have written something this indication of CT-MR angiography, which sir has covered, like RCC with IVC thrombus, clearance of tumor thrombus plane, degree of occlusion will be better, and you can get collateral circulation apart from the normal thrombus level. There are certain indication of transesophageal echo. It all shows basically done at the time of intubation. And you can recent things are that it can predict the adherence of tumor to the myocardium, and vascular clamp could be made exactly above the head of the tumor thrombus. It's a live type, or you can just go above real-time echo and you can just clamp the IVC.
Umesh, this will be for tumor thrombus.
Yes.
Level 2 above, 3 and 4.
Basically, level 2 above.
So this will be investigation at the time of procedure, not before.
Sir, this is done at after the intubation.
Yeah.
From endotracheal tube, they put on transesophageal echogram, and then real-time thrombus can be watched and managed.
Yes.
Then this has been covered. Nothing specific. Chest X-ray.
And Umesh, come to previous slide.
This one?
Yeah, I think this we missed it. This patient had a blind thrombus also. I think he should know about the management of blind thrombus also. The different ways, level up to like vein, you can put filter. It is up to the renal vein, but distinct pain is there. Then you can have what you can say the ligation or stapling or the suture ligation of IVC. That is the thing which we missed.
Yes, sir.
Okay, so yes.
There is one classification I want to mention that residents should know about the Navy's classification. This is basically a Mayo Clinic Navy's classification. This is all they know, but they should note the name of. And this is very good slide which shows level of thrombus and their management simultaneously. So they can copy it. Rest is okay, sir. And you have told that indication for preoperative embolization. That left renal artery embolization can be performed 1 to 2 preoperative, because this I found that this helps because renal arteries.
Right.
Thank you, sir. This is
okay. So I think, sir, Dr. Raval wanted to just have one comment on. Yeah,
Dr. Raval is there. I think let us ask Dr. Sudhir Raval to comment, and then you can take over.
Yes,
He has a
Dr. Raval, sir.
Yes, sir. Actually, I was looking because this was uro-oncology case. So just a minute, give me few minutes, 2 minutes just to put in my headphone. There are, it was very well discussed by Sabnis and Dr. Arun and Vani. I just wanted to say a few things to these guys. I am not an examiner for urology because I just do uro-oncology, so I don't come for as examiner because I don't know about a stone and a stricture and TB. But when you come for metastatic disease, there are 2-3 things when we see, or locally advanced, we always do FDG PET scan, which is very informative. Rather, there's a guideline for the patients. It may not be picked up by primary, but in metastatic side, it is very well picked up. And when you do this surgery, you have to see, as Sapnis has already told you, that about whether to do adjuvant therapy and what are the indication of adjuvant therapy. There is another indication which I would like to add is, if there is extranodal extension in the node when you're doing lymphadenectomy and everything is grossly, there is nothing. But if there is extranodal extension, then you have to have a close watch. Adjuvant may not help, but then they are the candidate which have early recurrence. There is another situation when you have removed the tumor completely. There is no disease, free thrombus, everything, but there is a single node sitting in the single tumor or nodule sitting in the lungs. These are, or maybe the bone, and elderly patient, there is no need of treatment. You just follow them up. I remember Dr. P.B. Desai, who was director of TMH, always showing one slide that minimal metastatic disease in any cancer should not be treated aggressively, because many times these patients, they just have a small mets, and then you can follow them up. That is my comment. Thank you, Anup.
Okay, so thank you very much, Dr. Umesh, for excellent case moderation, and thank you very much, our esteemed teachers. I think both the cases, they were extensively discussed, and it was all the students, they must have gained a lot of knowledge from this case discussions. And I just want to emphasize that whenever you get this kind of cases, you have to divide your Y1 to 3 parts. History examination is the first part, and you score here good. Then you move to the investigation part. And investigation part, once you clinch the diagnosis, the third is the management part. So for passing your exams, you have to fare well in all these 3 parts. If you fare poor in any of the parts out of these 3, you might have to fail in this examination. So please divide your case into these 3 parts. And as you have seen, these esteemed teachers you might get in your exams as the examiner actually. So that's why we call all those teachers who are taking the exams for many years, so that you get idea what kind of questions are asked. And this year, all the exams will be virtual exams. So I want to thank again the moderators, Dr. Umesh Sharma, Dr. Gautam Chaudhary, our teacher, Dr. Sabnis, Dr. Chawla, and Dr. Salim Wani for giving their precious time. And as I told, more than 500 delegates, they were watching from various platforms, and that showed the interest in this program. And also want to thank Navneet ji and his team for his technical support. So thank you very much for joining us today. And I hope we will have the last program in the last week, and that too also will be beneficial for all of you. Thank you very much, sir, for joining us today. And have a great
everyone. Thank you.
Thank you.
Bye-bye.
Thank you, Anup, from our
Stay
side
safe.
also. Thank you very much.
Bye-bye.
Thank you.